Our goal with this panel is to have a very real discussion about how the Choosing Wisely lists, new and old, and the campaign itself can be put into practice to reduce unnecessary care, and our honest reactions about what kind of impact we're going to make and what might we expect for the future. So first off, I'm going to introduce everyone on stage and say a little bit about them. You've got their bios in your packages. They're a distinguished group, and on my right, your left, is Dr. David Longworth. He's the chair of Medicine Institute at Cleveland Clinic, and he's a team leader of the Value-Based Care Steering Committee at Cleveland Clinic, which is widely lauded as having high quality and efficiency. Dr. Deborah Whitman, an economist. We have two economists on this panel, I want to tell you. An executive vice president of policy at AARP, which we all know is one of the biggest membership and advocacy organizations in the United States, and one of the best, biggest and best. And Dr. Gail Linsky, another economist, currently a senior fellow at Project Hope and a former administrator at Healthcare Financing Administration under the first President Bush, and that is now known as the Centers for Medicare and Medicaid Services, as you know. Then we have a substitute, Dr. William Zogby from ACC, American College of Cardiology, took ill, not seriously ill, but serious enough not to get on a plane. He was getting chills, and it looks like he had a little bit of a cold and a fever. But we recruited an excellent substitute, and we've known him from the first go-around, and his name is Dr. Glenn Stream. He's from the great city of Spokane, Washington, and he's a practicing family physician, and he's the past president of the American the American Academy of Family Physicians. And joining us from the perspective of the business community, we have Jim Knutson. Jim is the risk manager and human resource director of Aircraft Gear Corporation in Rockville, Illinois, a manufacturer of components for the aviation and auto industries. I'm sure you'll rush to get products from him after this meeting. Now, my job during this panel is primarily to help us cover as much ground as possible by offering some questions for discussion and moving things along. So let's dive in, and I'm going to dive in by asking Gail, what are your reactions when you first heard about Choosing Wisely, Gail?
A terrific idea, very promising that physicians representing different societies would band together, voluntarily try to identify areas that they in their own specialties thought were overused or had minimal value. I am an economist, and so while I think putting information out first is important, I applaud the notion that had been referenced earlier that it's not only having information disseminated to the practicing physicians and to the consuming public, but important to get them in terms of guidelines or other more directives, but even more important with reporting. Reporting seems to have a measurable impact on behavior, but I am an economist, and so it's like doing all that is terrific. But I could see a time where use of measurements like this would also feed into payment. And I think we ought to think about how to do that sensibly. As was said, these are not never events, so we need to be thoughtful about how we do them. But just as groups like NCQA and other groups report the percentage of women in the appropriate age group who have mammograms done, you can imagine the reverse, reporting the percentage of unnecessary or less likely to be necessary tests being done as an indicator of something that ought to be raising questions. And I think beginning to think of strategies that will lead us to treat smarter and spend wiser is what we all have to do. And it's reassuring to have the group who are most responsible for this information, the physician community, band together and say, there are things that we're doing that don't fall into the spending smarter, treating wisely category.
So let's go back to when the Affordable Care Act was being debated. We often heard that it would lead to rationing, and would you say that choosing wisely is different than rationing?
Oh, it's absolutely different than rationing. I was one of the people trying to raise a voice on the other side of let's be careful how we use these terms. It's not going to lead to better decision making. What we know we need to do more in this country is do those things that are empirically justified, to move more to evidence-based medicine. There's nothing rationing about doing things that make no empirical sense. We are a country that tends to think more is better. And this is helping to get people to think, in many cases, less is actually better. It's not just that doing no harm, it's actually better, because there are risks in many of the things that are done unnecessarily and unwisely. Getting that message really out and embraced is going to be very difficult. And I think actually getting it to the physician membership is no small deal. I'm thinking back on my personal experience, my few and occasional encounters with the healthcare system, where my physician has been suggesting some of the tests I see on here, and me as an aggressive patient saying, why are you suggesting that? That's something where we need to see really active outreach by the leadership of the societies. I'm very impressed at this first round. It's the first round, and I really hope that you get medical societies and your meetings to have this be included, like apparently the ACC did at one of their recent meetings, where this becomes something that's really a drumbeat.
Excuse me, Daniel. I was just going to add that I think we've already been rationing. We just kind of do it on. We've been doing it on the basis of eligibility. We've had, maybe 50 million uninsured, and so we've allocated resources that way. And I think this is a step up over that.
Thanks, Jim. So I'm going to turn to you. I'm going to turn back to you, Gail. Don't worry. Dr. Longworth, what did Cleveland Clinic think about the list? And are these lists helping to change culture and attitudes about physician responsibility to choose wisely and use resources wisely?
Well, absolutely. First, I want to thank the Foundation and Consumer Reports for leading this campaign. We think it's vitally important. We think that the drive to value for healthcare delivery in this country is a profound and fundamental issue of our time. And we think that this initiative supports that in a couple of different ways. First, as Gail has mentioned, removing unnecessary care from the discussion and trying to emphasize quality and patient safety, but equally important, to try to engage patients and to activate patients and to take responsibility for patients. As we think about improving value in our society, certainly we as healthcare professionals have to do that work, and choosing widely is a platform to begin that discussion, but equally important is the conversation you had. I wish patients would come into my office and challenge the tests that I recommend. That doesn't happen nearly enough. Instead, they come in as a transactional relationship. They want something. They want that antibiotic for the upper respiratory tract infection. They've got acute back pain. They want to be imaged, and they want to be imaged now. So what choosing wisely does, I think, is begin to stimulate patient engagement and patient activation. And so does Cleveland Clinic embrace it? Absolutely. And what have we done around it? We have embedded into our clinical practice guidelines the first recommendations so that physicians and providers can pull that up on a screen and show those to patients in the examination room and say, do we really want to do this? Here's evidence from across the country in specialty societies that this makes no sense. We are embarking on educating physicians in our community. We have a large physician organization called the Cleveland Quality Alliance, and those are a group of both employed and non-employed but aligned physicians, and they have endorsed Choosing Widely as well and are publicizing it throughout the greater Cleveland community. So yes, we fully support this initiative, and I hope that addresses your question.
So let's answer Andy Weber's question. What success of this campaign look to you like?
So the success of this campaign to me looks like a couple of things. One, we focus increasingly on appropriateness of care. And to the question that was asked earlier about measuring it, I do think we need to begin to measure it. And in fact, at the clinic, part of our annual professional review looks at appropriateness of utilization in a couple of these areas, not nearly all of them, but I know how my primary care physicians are doing around inappropriate antibiotic prescribing for upper respiratory tract infections. I know that information, and we discuss it at the time of the annual professional review. We are embarking on a journey at the clinic to build care paths around a whole variety of different disease processes, and part of those care paths will be around appropriateness of testing. And so to the point that was raised, we're building systems where we can measure appropriateness moving forward. So I think that measurement and feedback of measurement will be an increasingly important step in changing provider behavior. And ultimately, I do agree with the comment that the payers are going to want to see that information and reimburse accordingly.
So we look forward to seeing a research paper from Cleveland Clinic on this experience. Thank you.
Stay tuned.
Okay, Dr. Stream, who practices in Spokane, Washington, are you seeing conversations happening in exam rooms around the Choosing Wisely or about overuse?
I am, and I hear from my colleagues when I visit people around the country in our various chapters around the country are seeing this from their patients because of the media outreach that's an essential part of this Choosing Wisely campaign. It makes it much easier for that physician to decline the imaging or the antibiotics if the patient comes in with some prior knowledge before they're acutely ill that makes them sort of feel like they need more done to them. If they have some prior awareness that more isn't better and that some overtreatment actually carries risk of harm to them, it makes it easier for the physician in collaboration with their patient to make the best decision. I think we have a ways to go. In one of the media interviews I did earlier this week on the issue, somebody said, is this the last 5? Are you guys done? I'm like, I think there's a lot more to be done. There'll be more information that becomes available about things that have been standard practice in the past that are now recognized to be overutilized. I was very excited about the expansion that's coming forward as far as additional specialty societies. I suspect most people here didn't realize there were that many medical specialty societies. But we have work ahead of us, but I think for the 10 months it's been going, there's been great progress.
So what kind of resources could help this advance in the exam room? What other things might be useful in the exam room for this campaign to be successsul?
Yeah, and again, I think a lot of it has to be in advance of that exam room interaction between patient and physician. It has to be in advance, and that's the really critical piece to this campaign. And when people ask me what's unique about this, many of the top 5 that our academies are bringing forward are not necessarily new information to the physicians in our specialty, but they are new information to patients. And to get that information out for that very important treatment and testing discussion, for that shared decision making that really is the future of a more efficient healthcare system and more patient-centered healthcare system. Having that information out ahead of time is really important. And my hope is as we go forward that isn't just press events like this, but it trickles out on a regular basis of information so that people see it in multiple sources, multiple lines of communication. My academy has a patient-facing website, as pediatrics mentioned. Ours is called familydoctor.org and has a number of patient resources covering these sort of items and many others, also available in Spanish, certainly recognizing the need to get to our Spanish-speaking patients. Interestingly, a significant majority of the access to the Spanish-speaking part comes from outside the U.S. So I think that we're getting even outside the U.S. with a lot of this information.
So you've done 3, you're going to be doing 3 lists. Is this going to continue? What do you think is?
As I said, I don't think we're anywhere near done. I hope that this next 15 organizations coming on board later this year are not the last. And I believe that many of the associations represented here will be able to identify multiple sets of more 5. I hope that we start to see, as we did between American College of Obstetrics and Gynecology and the American Academy of Family Physicians, more collaboration in the development of those. I think it extends our reach both to members, physicians, but also to our patients. And I think we've only started this journey.
Great. Thank you.
One more time again, Dan. Sorry about that, but it seems like this approach is, in the past, we've kind of taken more of an adversarial approach to like denying care. We've used utilization review and you know, kind of the implication being that it's about cost or being cheap. And this has a better feel to it based on information and collaboration. And I don't want to get too campy about it, but I just think it's a better.
Yeah, if I could tag on, I agree completely. The objective input of traditionally public-facing partners like Consumer Reports, like AARP, who are trusted sources of information and not seen as part of the healthcare system, like the healthcare provider or the payer, as a barrier between something that the patient thinks they need and perhaps they don't. Having it actually have that platform of like Consumer Reports, where it's objective, in their best interests, I think is a huge and important component of this campaign.
We talk about partnership, and we also talk about professionalism and action of physicians really stepping up to the plate. So, Deborah, let's get away from all that physician talk and talk about your voice representing the consumer and patient, and I'll ask others to chime in as well. But what else should we be doing to reach the general public about choosing wisely and overuse?
Well, first of all, AARP is delighted to be a partner. We have 37.5 million members who use health services on a fairly regular basis and are looking to encourage a better conversation with their doctors. What I liked about the Choosing Wisely information was it didn't just say this test is bad or don't do this, but actually talked about the impact. For instance, the overexposure to radiation, or on the AGS recommendations, the potentials for falls or accidents from certain medications. I think that really spurs a conversation between the patient and their doctor and is really important. The more we can do to get this information in the hands of consumers, the better. I don't know if all 22 million hits on Wikipedia were from our members, but it will be part of our bulletin, which is one of the largest publications in the world that hits 26 million households. We also work in conjunction with Consumer Reports to try and make sure that the language that we put out is consumer friendly and well understood. I think the more we can get that in the hands of people at the time they need it and in a form that they can understand and appreciate, the better.
So I just want to publicly thank AARP for the support, and the campaign has just been fantastic. Thank you so much. So I want to open that question up. What else should we be doing on the public side in this campaign to get the message out that more is not always better? Anybody have it?
I think, excuse me, I think we need to look at what is going on as an important enabler of change that needs to be part and parcel of a lot of activities going on now in order to try to bring more rationality to how we use healthcare and spend healthcare resources in this country. I don't want to overburden our expectations on the Choose Wisely. I think this is it's terrific that the people best able to step forward and say, in our specialty, these are tests that are done too often. It's, again, not a never event, but under limited circumstances. If we're going to get a different outcome from what we've seen, which is rapid growth in healthcare spending and not the best outcomes that we'd like to see for our country, we need to understand it's going to require doing a lot of things differently, paying differently, paying for high clinical outcomes, good quality clinical outcomes, efficiently produced. We need to enable physicians and patients to understand how to get there. We ought to regard this kind of information as an important enabling source for the physician community, for the patient community, getting it out to the consumer groups like Consumer Reports and ARP and all of our other consumer groups. Maybe it will help in some of the liability issues where physicians feel challenged that if they don't do various tests, even if they think they're only marginally or even unnecessary, they put themselves in some legal exposure. Having groups like this and the specialty societies indicate that these are not common steps of care, ought not to be regarded as either evidence-based or the standard practice of care can help. But it's going to take a lot of changes. Information, and again for me as an economist, having the right financial incentives in place so that we reward clinicians and institutions and patients for doing the right thing in terms of taking care of themselves and using healthcare in responsible ways, and give them all the tools that they need. So I don't want to overburden ABIM and all of the specialty societies of saying, in and of itself, this is going to solve our problem. But for me, to answer Andy's questions, actually, it's easy to know what your impact is. A couple of years from now, go out and measure the number of times or the proportion of individuals who are having marginally necessary tests done on a routine basis, and you'll know whether or not you've had an impact. You can claim all the credit if it happens. Hopefully, there'll be other enforcing or encouraging mechanisms to push you along in the right direction. But it would be very hard to happen without this. So it is a really important enabler, and that's how we ought to look at it from my point of view.
And I want to challenge every delivery system to begin to adopt the recommendations and measure and do research papers to really see the impact. And I think that's where it's going to happen. Let's go to Jim. What about engaging employees on these issues? Have you implemented any efforts around these issues, and how did they go so far?
Yeah, we were introduced to the subject, pretty close to a year ago. National Business Group on Health and Midwest Business Group on Health both picked it up quickly, and so we had presentations. I believe Dr. Castle even came to one of our committee meetings, and so we learned about it, and then we took it up in Rockford with some of our local providers. They were interested in it. They had heard about it about the same time, and they're more than willing to do, I think, some pretty interesting stuff. We've had physicians from St. Anthony's Hospital come out, for example, and talk to our workforce about the subject matter and try to set the plate, talk about the issue in sort of a setting that the audience is more comfortable with. When you're in an exam room, your mind is kind of cluttered with panic, and you're not always remembering everything you heard. But it's when the docs were willing to come to the workforce and talk about it, it seemed like it resonated better, and so we're going to try to keep it up.
And we're looking forward to Andy Weber, who is developing a toolkit for employees, for employers that will give to employees about the Choosing Wisely campaign. So we're really thankful for Andy and what the work is being done by the employers. So let's go back to Dr. Street. And we've heard from physicians how difficult it is to say no to patients requesting specific tests or procedures. What's your reaction to that, and what's your suggested solutions to that?
It is sometimes difficult, especially when someone is as describes, the patient's ill and they're anxious, and that I think feeds this tendency that we have to think that more testing and more treatment is likely to be helpful. We're on a many-faceted journey to reform our healthcare system to make it higher quality, more cost-effective, more equitable as well. I think back to your original question to me about how do we get that into the exam room is it isn't a pamphlet that I'm going to pull off of a shelf or anything. One of the other facets of this journey is implementation of health information technology throughout our healthcare system. And we need to embed this in every aspect of that possible. The public-facing, patient-facing information resources that Cleveland Clinic is very well known for, and certainly other entities as well that can present patient information generically, but often patient-specific information about, I'm a patient with diagnosis X, and here's information for me about that to make it really targeted. But also for the clinician in the exam room, physicians are busy, partly aging of our population, more chronic illness, an undersupply of physicians. People are in a hurry sometimes, and that can detract from doing all of the necessary things of care. I'm a health IT geek in addition to seeing patients, and I like to say that no matter what version number somebody puts on their hospital information system or ambulatory electronic medical record, they're all 1.0. We have a long way to go in making these physician-centric enable rather than challenge the workflow of actually caring for patients. So, for example, the electronic record in my practice will advise me if I'm trying to give an antibiotic that somebody's allergic to. It will advise me if I'm giving somebody a new medication that's going to react with an existing medication. But it doesn't tell me if I'm ordering a test for which there isn't good evidence. And I think that that's the next step that we need to go to. And it needs to deliver information not just to me, but I like to turn that screen to the patient and say, here's the best evidence, and this is why we really don't need to do this treatment, and it actually is in your best interest rather than in any way not delivering care that you will benefit from.
So it's maybe along the lines of Cleveland Clinic, some medical support decision-making. So I want to go back to you and ask you about what's some solutions to having to say no, and what's your take on
Well,
that?
amen to all of the comments that he made. I do think that this is not just about layering on additional work at the point of care in the moment, because physicians are busy, providers are busy. This is vitally important, and it takes time to talk to patients about these issues. So what we're doing are several things. We're redesigning our workflows. We're taking non-doctors' work off the doctor's plate so that they can be in the moment with patients and have these kind of conversations. We're trying to get rid of the clerical stuff, the health maintenance things we're doing pre-visit to identify and flag. So part of this is about workflow redesign. And then to your point around clinical decision support, we are building those types of alerts that say, this is really not an indicated test, to try to prompt providers to know what's right and what's wrong. And most doctors want to do the right thing. They want to do the right thing, and you just have to communicate what those things are. I do think, though, there is a little bit of a tension that we haven't said out loud. Despite the fact that doctors want to do the right thing in value-based purchasing, we're paid for patient experience. And I see every ombudsman report in my institute on a daily basis from the day before. And a lot of those reports are about physician communication, but a lot of those reports are that the patient didn't get what they wanted. And that often wasn't indicated. And I'll send it back to the provider or to the chair, and I'll say, something? The doctor did the right thing. But when it comes to our patient experience scores that are going to be a part of value-based purchasing, there is a tension. And so I think the answer to that, going back to what you said we need to do moving forward, I don't think we can over-communicate on this issue. To patients, to providers, to employers, we need to reframe expectations and educate people about what is and is not appropriate.
So one thing that the ABIM Foundation has been involved with some of the specialty societies in Phase 1, and particularly in Steve Smith as well, under a grant that we gave him, is really teaching communication skills around how do you say no. So at the end of the time, the patient feels pretty good about what has been said and feels secure and feels like being taken care of. So we're going to roll that out, and that hopefully be a useful tool, but I agree with your redesign as well.
So I'd love to comment on that. We have a formal communication program at the Cleveland Clinic through our Office of Professional Staff Affairs, where we teach the 4 habits in communication to engage patients. I have mandated, and I rarely mandate as a leader, that every member of my institute take that course, and we are building that into our medical student and our residency training programs to teach communication and emotional intelligence to better engage patients around care delivery.
And give me the 4 habits, could you please?
Begin with the moment. Greet. Listen to the patient. Reflect on and take into account what the patient wants, and then close the moment. I haven't gotten the language exactly right, but it's basically to greet, engage, listen, and thank the patient.
Good, thank you. Gail, going back to you, realizing this is a sensitive subject, so I want to approach this completely hypothetically. Is there a role for government in choosing wisely?
It's a nice thing about running Medicare and Medicaid and sharing MedPAC. There are a few things that people can throw at you that throw you. Absolutely. As I was listening, especially about the Cleveland Clinic experience, but also thinking about my various conversations with family physicians, it's one thing to say physicians ought not to suggest or even perform readily unnecessary, unwise tests. It's another thing to have payment that drives them in exactly the opposite direction. And so as important as it is to provide this information out for assurance to the patients and for information to the practicing physicians, we have got to develop payment systems that reward the kind of behavior we want to see. Medicare is the worst offender when it comes to physicians. There are a lot of things wrong with how reimbursement occurs.
We're close, though.
Yeah.
We're
There is nothing worse than paying physicians on the basis of 10,000 individual items through the CPT codes for what they provide, and then wondering why we keep fighting this notion that more is not always better. In fact, less is frequently better. And it's not that this is the only driver, but it is a really hard financial incentive to encourage people as physicians and as users to do the right thing when they are being financially pushed in the other direction. So there is no question the little seedlings that Medicare is beginning to plant, either in terms of value-based purchasing or the value modifier that's supposed to start kicking in 2015 for groups of physicians, that we begin to pay on the basis of what we want to see provided, which is good clinical outcomes, efficiently provided care, so that we can support the kind of behavior that we want to have go on. Government can definitely help by helping the dissemination of information. It is better to have it not just be government, and it's terrific to have it come from the physicians and the medical societies, however they want to arrange themselves. Because without that help, there's always some suspicion, and it's probably highest level of suspicion when it comes from CMS because they're the payer. There's always that sense of, are they saying it because they just don't want to pay for it, which is very different than when the medical societies embrace it. So CMS, government in general, needs to do a better job of paying for what it wants to have happen as opposed to what it says it doesn't want to have happen, which is more and more complex procedures, whether or not it's actually the best for the patient's clinical outcome. It has to be supportive of information dissemination, but it really needs to rely on the professionals, because if it's not embraced by the professionals, it's going to be a losing battle at the end, because when there's a question between who do I trust, the evil payer, Medicare or private payer, or my individual physician, hands down the physician is going to win that battle. It really is important to have the physician join these efforts, be informed, but also be enabled and encouraged to behave in the way we all would like to see healthcare goes. So it is a big role for government.
Thank you. Deborah, do you want to comment on that?
Absolutely. I think most of the conversations going on with the rising costs of healthcare are sort of broad swath approach that don't necessarily improve quality. Take the sustainable growth rate for physician payments. So across the board cut to physician payments, or limits on the number of visits to post-acute care, or those types of ways of addressing health costs, but not addressing at all health quality. What I like about this is it's evidence-based. It can actually improve the patient experience. It can improve the quality of care, and it might save both the payers and the consumers a good deal of money. So this is the direction we need to look at when we're talking about having a lower cost health care system, one that's more efficient and one that meets the needs of patients.
I've always said that if this campaign was happening 5 years ago, we wouldn't be sitting here. I think we're in the right environment to be receptive to the ideas of choosing wisely. Jim, we want to bring you in again. Do any of the existing strategies that you see playing out, Jim, the value-based purchasing or pay-per-performance, have any chance of being able to make an impact? And what are the advantages vis-a-vis those strategies to choosing wisely?
Yeah, I think the refocusing the way that we contract and cover healthcare services is really critical. Dr. Walensky pointed out we're incentivizing in the wrong way, and yeah, I think it was Don Berwick who said once, every system produces exactly the result it was designed to. And when I think back to the 70s, we insisted on fee-for-service then because we had something like global payment, but we wanted to see exactly what every item we were being charged for was, and so that's what we got. We got 45-page line item bills, and so we shouldn't be surprised by any of that. But when it's not working anymore, we should change it. And so I think, to the extent that CMS could maybe sync up with like Andy's group, and develop a standard, a uniform set of measures to evaluate performance, and understand that it might be a little clumsy at the beginning. When I think back of things like smoking cessation, when we started asking physicians to counsel on that, we'd put a box, and they'd check the box, mark, yep, smoking cessation. We couldn't really evaluate the quality of the encounter, but that was a first step. And I think a lot of our measurement activities are just that. They're a progression. You got to start somewhere, and then you get better as you work at it.
Well, this is actually going on a little more than you might know. For example, in PQRI, the Physician Quality Reporting Index, that was developed by bringing together large numbers of representatives, and the NCQA in general has been bringing together various groups, including the government, and having participation between public and private groups trying to do measurement. One of the biggest challenges is going to be to make sure that we have a manageable number of metrics and that we get as much uniformity as possible. When the Accountable Care Organization proposed regs first came out, there were 66 quality metrics involved. The final rule, mercifully, reduced those to 33 metrics, still not a small number. Payers need to make sure there's as much collaboration, so there is a minimum burden impact, and that it is the smallest number possible to get the job done, and to recognize and asking for measures. We are going to be taking away somebody's valuable time from providing patient care, either the physician or the nurse or somebody in the office. And just as we've got to teach medical students and residents and practicing physicians, don't order tests if your clinical decision-making is not likely to be influenced by the information that you receive. We've got to get regulators and payers to think about why they think they need a particular measure. And if it's not really a good indicator of quality outcome, drop it. Don't include it just because it might be nice to have around. All of these things have burdens and impose real costs in terms of having somebody not doing what they otherwise ought to be doing. But we're actually further along than it might sometimes seem from the outside, just not nearly far enough.
So let's go back.
Start with the square root of yellow, and we'll eliminate that one.
Okay, let's go back to you, Jim. How can businesses and employers support the transformation we're seeking in choosing wisely?
Yeah, I think it's just kind of first stop making it worse. You know, when healthcare is kind of messy and full of unintended consequences, and so when you sit down for collective bargaining, for example, and there, if it's about the benefit package, to remember that's a setting where more is always better, and it's victory if you get more, and so just I think being aware that you need some balance in your approach to a lot of your activities, so they don't kind of work against each other. One other thing that I think has some potential that we're working on, you know, the concept of a warranty in healthcare and purchasing on that basis is becoming more and more prevalent. And to, you know, we talked a little bit about liability exposure, and to introduce that topic as well, we're working with some providers now to package the notion of warranty disclosure more in the misuse category certainly than an overuse, but and in exchange for that, providing some sort of meaningful malpractice or tort reform, liability limitations, liability caps, and I think that's really got some potential.
So, Deb, let's go back to you. Do you think that consumers and patients are becoming more aware of the issues that we're trying to raise as a result of the Choosing Wisely campaign? Are we going away from more is better to less is better?
I think we have to as a starting place, because we see our members already spending, particularly the older ones, a quarter of their income on healthcare. These are real choices that people are having to make of whether they can have other resources to, you know, turn their furnace on. So, but they want to make sure that they get the best quality care. So what I like about this conversation is it provides information that ideally is readily available through the partnerships that we have and is easy to understand for consumers, that helps them to have those conversations so that not only can their healthcare experience be better, but their own out-of-pocket costs can be lower. So it's a multi-part conversation, I think, on a lot of these issues. Getting the information in the hands of consumers at the time they need it, at the time a doctor's visit is happening, is very difficult, and that's why I think the direction that Cleveland Clinic is going, where the doctor can have a conversation, turn the screen around, and have a more in-depth conversation about why at this moment this test is not appropriate for you, I think is really essential. For other things that are longer term, I have chronic sinusitis. I was very interested in the reasons why my primary care physician should reject every time I ask for antibiotics. I will try and hold off in the future on those. So some of the conditions that are chronic, being able to look at the specialist society and understand how those imply for your own care, I think are useful. But other of the recommendations are really very time sensitive and do rely on that conversation between the doctor and the individual. But our members, and I think most healthcare consumers, are price sensitive. They want value from their healthcare. They want to know if I'm going to pay for this X-ray or the CT scan, it's really necessary to improving my care. And so I think there is a real role for a partnership here on multiple levels.
You're seeing more price sensitivity by the elder population?
When we look at how much they're spending on healthcare, absolutely. When we look at basic things like use of prescription drugs and people are cutting things in half, people are foregoing necessary care, these are real issues, not just from a federal budget perspective, but from a family perspective. We did a study recently on credit card debt, and the vast majority of people that have credit card debt over age 50 used it to pay for a healthcare expense.
One of the issues of how to communicate to the right audience is going to require a lot of thought. I don't remember who said that trying to gear it for a 6th or 7th grade education level is something that was being done. Remembering that if you are going to try to prepare information for the most likely users, that is going to require a lot of differences depending on who those most likely users are. And I've had this experience as somebody working in survey research of designing what you think is a really good questionnaire that will give you all the information you want, and then going out and being an observer when somebody tries to ask your cleverly designed questions and you see the completely blank look on the face of someone trying to answer them. So having the audiences at the right level be responsive and helping you know whether you've developed good information is just a great way to go.
So I'd like to comment on that from the perspective of the clinician at the bedside. To your question about are we gaining ground, I do think we're gaining ground with the Dr. Walensky's of the world, who are sophisticated healthcare consumers. Absolutely, we're gaining ground. Those people come into my office, they ask all the right questions, but I worry about the uninsured, those vast numbers of people who are going to come onto Medicaid, the dually eligibles. I see those people. This is a completely different discussion for those people. This is not on the radar. And to the extent that we need to figure out how we're going to make this successful, we do need to tailor how we're going to deliver the message, what the education is going to look like. It's going to look a lot different, I think, than it does to the Dr. Walensky's of the world who completely get this discussion.
Okay, so I'm going to ask the big question, and I'm going to kind of box it off a little bit. Okay, we've got payment reform. And so what's missing from the Choosing Wisely campaign? What could we be doing to make this more of a success? So we're gonna go around. I hopefully have time for everybody to say something, and then we're gonna close.
Well, I think this is a fantastic beginning. Like others have said, it is only a beginning. It's about improving quality, eliminating waste, driving towards value. But I think at the end of the day, there's another discussion to be had in this country, and that is about choosing wisely about healthy lifestyles. How are we going to stem the epidemic of obesity, substance abuse? How are we going to address nutrition and exercise? We need to be thinking about, and it may or may not be part of this campaign, how we're going to choose wisely around those issues so that at the end of the day, we're having fewer discussions about choosing wisely about what tests should or should not be done.
So upstream.
Upstream.
Deborah.
I think as we debate the rising costs of health care, and with the recent IOM report that a third of it is unnecessary care, what we have to be doing is looking at examples like this to have a patient-provider conversation about the ways to squeeze out that waste. This is exactly the direction that we need to be going rather than rationing care or continuing to raise the cost of the healthcare system.
Great. Gail.
We need to recognize this is a multifaceted problem. We've had the outcomes that we have because we have a healthcare system that is designed and encouraging everybody involved to do more and spend more. And if we're going to change that orientation, we need to have a different set of incentives that encourages us and rewards everybody to do what makes sense. And that I couldn't agree more on this notion that understanding how we as individuals choose to live our lives is going to overwhelm anything that our healthcare system is likely to do. But it doesn't mean we can't try to make it easier and rewarding and encouraging behavior like the choosing wisely as an important enabler, one of many. But again, I'm worried. Let's not put so many expectations on an effort like this that we doom it. It's a terrific enabler and one of, I hope, will be many changes,
And hooked and connected and partnered with many other initiatives,
including those financial ones.
I think we're on a good trajectory. I think a lot of this is just stay the course with the expansion that's already been outlined, additional organizations coming online, more of the top fives coming forward, I think is good. We've often been asked, what do we think about participating in this initiative as an academy? When it came to my academies for discussion, it was really, well, why didn't we think of this? It's like most great ideas, when somebody comes up with it, you say, duh. But congrats to the foundation for being so far ahead and doing such a great job in the leadership that it made sense for all of us to come in together. What I heard in Dr. Castle's comments was, she didn't lay it out this way, but sort of a challenge, how some specialty academies have been promoting this to their membership, and doctors are very competitive. So I can see, can you top this as far as communication to your membership, getting it out through vehicles? Our academies, being fairly large, has a lot of communication vehicles to our members, but I mention it when I visit state chapter meetings. I encourage our other board members to do that. We have a large annual meeting. There's a number of venues where we, as current partners, can go to the next level in getting it out to our members, as well as our public, consumer, patient-facing partners really need to maintain their effort, because I think that's where we really have to make some more ground.
Great, thank you. And we're going to count on you guys to push it down to the patients and the physicians, so we're counting on you.
Problem with going last is all the good ideas already got taken. But one thing, actually two things. One, I think on healthcare we fatigue easily, so we ought to be aware of running out of gas early on something like this, and we don't want to do that. And then the second thing is, I just echo Dr. Walensky's comments about contract. We need to reform our contracts, and we need to reform our coverage clauses. We've been using something like medical necessity for 70 or 80 years as a coverage clause, and it's probably got to go.
Well, we're going to come to the end of our time here this morning, and I wanted to thank all you for joining us today. What'd you say? And it's been phenomenal conversation, and it's been inspirational. So I want to, with that, turn to Chris Castle for the last word. Chris.
Thank you. Thanks to the panel. This is really, I was taking notes. I think many of us were. And I want to really think about. Oh, there we go. I want to really think about Jim's last point about not running out of gas too early. I've been thinking about this in talking with our board about it, that while this event is coming to an end, the work really hasn't. And the Choosing Wisely campaign really is about more than lists. The lists are the raw material for the communication and for the behavior change and for the system change that our panelists have been talking about. One way to think about it that John Santa of Consumer Reports conveyed to us recently is that this campaign needs to turn into a movement. And a movement is where nobody any longer owns it. And it really is sort of part of a groundswell of how people think and how they behave. And I would even take it farther than that, from a campaign to a movement to the new normal, because that's really what it's going to have to be in order to be to allow our healthcare system, with all of the advances that all the medical specialties who have joined this campaign represent, to actually be affordable and available to all the citizens and all the people who need them. So as our board thinks about this, we think about the responsibility of stewardship of this effort, but not about the ownership of it. We think about how can we keep it alive and keep it vibrant, and the answer to that really is with our partners, that it becomes embedded in the activities of professionalism and the societies and of the consumer outlets and communicators who help to keep that information alive. So it's a moment to celebrate as well as to be conscious of the need for that stewardship and the need for this to continue, and to welcome yours and anyone's ideas through our communication channels about what other thoughts we should have about sustaining it, what kind of research academic partners might be doing, et cetera. So this really is professionalism in action, and in many ways a very welcome departure from conversations we were having about these issues just even a few years ago, as we now embark on what will be a continuing effort to improve our healthcare system, make it better, produce more quality, safer for patients, and more affordable. You can follow the developments of this campaign and what everyone is saying and doing about it on our website, choosingwisely.org. You can also join the conversation on Twitter at #ChoosingWisely. A recording of this event will be posted on the website very soon, and I urge you also to check out Wikipedia. Consumer Reports, the AARP publications, and many other places where this information is highlighted.
And don't forget to read my blog post.
And read Daniel's blog post, right, exactly. I want to say that now a final thanks to our specialty society partners, some of whom had to travel long distances to be with us today, and whose work you saw displayed very briefly here. And include those who were with us at the very beginning, the 9 original societies, and those who've signed on for the third wave of lists, which you'll be hearing about. I want to thank Consumer Reports and the other consumer partners who are part of this journey, and particularly salute the commitment of the Robert Wood Johnson Foundation in supporting the dissemination of this work into communities. Together, we're taking very real steps towards transforming the nation's healthcare system, towards improving care, improving quality, patient safety, and making care more affordable. And as Gail Walensky pointed out to us, there couldn't be a better time. Don Berwick called this a game changer. The game is all around us. We're all trying to head toward these important triple goals, and we're just pleased and proud to be part of it. Thank you very much.